Module Overview. Palliative and end-of-life care is holistic by nature, requiring a synergistic collaboration among professionals from diverse fields. This module explores the structure, dynamics, and responsibilities of the multidisciplinary team, MDT, emphasizing how interdisciplinary cooperation enhances patient comfort, dignity, and family satisfaction. Healthcare professionals must understand not just their own scope of practice, but also the unique and overlapping roles of others involved in palliative care. The goal is to foster a cohesive, respectful, and ethically grounded team approach that honors the values of the patient and their loved ones, particularly in the emotionally charged final stages of life. Learning objectives. By the end of this module, you will be able to identify the core and extended members of the palliative care team. Describe the specific roles of each professional discipline in palliative and end-of-life care. Understand interdisciplinary versus multidisciplinary collaboration. Apply principles of communication, documentation, and role boundaries in team-based care. Analyze how teamwork improves patient outcomes and ethical decision-making. Recognize challenges such as role conflict, burnout, and communication breakdowns, and suggest remedies. Create and contribute to patient-centered care plans with clarity and empathy. Section 1. Understanding the Multidisciplinary Team, MDT. What is an MDT? An MDT is a group of professionals from various disciplines working together to deliver comprehensive, patient-centered care. In palliative settings, this approach is essential because the needs of patients span physical, emotional, spiritual, cultural, and social dimensions. Section 2. Core team members and their roles. 1. Physician, medical doctor, palliative consultant. Leads medical diagnosis and prognosis, initiates and adjusts symptom management, e.g., pain relief, nausea. Discusses treatment limitations and advanced care planning. Leads do not resuscitate, DNR, conversations. 2. Nurse/palliative care, nurse. Implements. Care plans, monitors vitals, and comfort manages pain and medication schedules. Provides psychosocial support to families, coordinates with other team members. 3. Social worker. Assesses family dynamics, housing, and financial needs. Provides emotional counseling and grief education. Connects patients with community resources. Facilitates guardianship or legal documentation. 4. Chaplain, spiritual advisor. Supports patients' spiritual and religious beliefs. Offers prayers, sacraments, and rituals as requested. Assists with meaning-making, legacy, and forgiveness. Provides spiritual guidance to family members. 5. Psychologist, counselor. Helps patients and families manage anxiety, fear, guilt, and anticipatory grief. Facilitates emotional expression and decision-making. Provides trauma-informed care in terminal cases. Addresses depression and PTSD in caregivers. Section 3. Extended team members. Pharmacist. Reviews and advises on medications and side effects. Physiotherapist. Helps with movement, positioning, breathing exercises. Dietitian. Provides nutritional guidance for those unable to eat normally. Occupational therapist. Adapts home environments for end-of-life needs. Bereavement specialist. Facilitates post-death counseling and grief groups. Legal advisor/advocate. Assists with wills, power of attorney, patient rights. Volunteers. Offer companionship, respite for caregivers, and legacy projects traditional or faith healers. Depending on the cultural context, especially in African communities. Section 4. Team communication and coordination. Key principles. Daily or weekly, MDT meetings to review patient status use of shared electronic health records. Open, respectful communication across hierarchies. Clearly defined roles and boundaries. Case conferences for complex decision-making. Inclusion of patient and family voices in the planning process. Tools for coordination. SBAR. Situation, background, assessment, recommendation. Shared care plans and progress reports. Interdisciplinary rounding and bedside meetings. Section 5. Interdisciplinary versus multidisciplinary models. Multidisciplinary, interdisciplinary. Each professional works in silos. Collaboration is integrated. Separate care plans, joint planning and evaluation. Less communication between roles. Constant feedback loops. Hierarchical leadership. Shared decision-making. In palliative care, interdisciplinary models are preferred for better patient satisfaction and streamlined care. Section 6. Team ethics and conflict resolution. Challenges may include role conflict or overstepping confidentiality breaches, cultural clashes, lack of recognition or burnout, family versus team disagreements on care goals, resolution strategies, ethical committee involvement, conflict mediation sessions, emotional intelligence training, regular debriefs, and reflective practice. Section 7. The patient and family as central members. Respecting patient autonomy and dignity, involving family in real-time decisions, adapting care to align with patient values and preferences, empowering families to co-manage care, especially in home-based palliative scenarios. Section 8. Cultural competence in team-based care. MDT members must be aware of bias and stereotypes, inquire about cultural practices around death, respect gender roles, religious practices, mourning rituals, collaborate with traditional leaders and spiritual figures. Example: in many African cultures, a patient's clan elder or religious leader may need to be consulted before major end-of-life decisions. Section 9. Accreditation considerations. To meet international standards such as WHO, NICE, and Hospice Foundation guidelines, MDTS must include trained personnel in grief, ethics, and spiritual care, demonstrate interdisciplinary functioning via records and audits, conduct ongoing training, evaluation, and quality improvement, document individual contributions to shared goals. Institutions pursuing accreditation must show team effectiveness, patient satisfaction, and continuity of care. Module summary. The strength of palliative care lies in the collaborative power of its team. By integrating expertise across disciplines and maintaining clear, compassionate communication, the MDT ensures that no need goes unmet and that every patient and family member receives the dignified, respectful, and holistic care they deserve.